the post-pregnancy red flag you must never miss. Abnormal bleeding with a beta hCG that is not falling as expected. That combination should immediately raise concern for persistent gestational trophoblastic disease. The most dangerous entity in this spectrum is choriocarcinoma, aggressive, early metastasis, but also one of the most chemo-responsive malignancies when diagnosed early. Today, we'll build a simple exam-ready pathway. Suspect it, confirm it, stage it, and monitor it. Trend beats value. A single hCG number is just a number. Serial hCG is the diagnosis. After evacuation, beta hCG should drop in a predictable downward curve. If it plateaus across serial measurements or starts rising, don't reassure. Investigate persistent GTD. In exams, this is where marks are won. Say, hCG is plateauing or rising post-evacuation, not just hCG is high. The classic presentation is persistent or recurrent uterine bleeding after a recent pregnancy event, especially after a molar pregnancy evacuation. Patients may also have pelvic pain, fatigue, or dizziness from anemia. The key clinical reasoning step is to avoid anchoring on retained products alone. Persistent bleeding plus abnormal hCG kinetics suggests ongoing trophoblastic disease activity and warrants structured workup. Choriocarcinoma spreads hematogenously, so symptoms can come from metastasis rather than the uterus. Lungs are common. Cough, shortness of breath, chest pain, or hemoptysis should trigger immediate concern. Brain metastasis can present with headache, seizures, or focal neurologic deficits. A high hCG pattern plus respiratory or neurologic symptoms after pregnancy is an exam classic for metastatic GTD. How do you define persistent GTD in practical terms? By abnormal serial hCG behavior after a pregnancy event, especially post-molar evacuation. You're looking for a plateau or rise rather than a steady fall. This is why follow-up is not optional. It is part of treatment. If the hCG curve is wrong, you escalate evaluation. If the curve normalizes, you continue surveillance until it is safely undetectable. Histo-only money clip. Histopathology is where the diagnosis becomes crisp. Choriocarcinoma shows malignant trophoblast, typically sheets of cytotrophoblast and syncytiotrophoblast, often with prominent hemorrhage and necrosis. The signature rule you must memorize is simple. There are no chorionic villi. That absence is the key distinction from invasive mole, where chorionic villi are still present but invade the myometrium. A fast differential that examiners love: invasive mole versus choriocarcinoma. In invasive mole, villi are present, and you see villous tissue invading into the uterine wall. In choriocarcinoma, villi are absent, and the tumor is composed of malignant trophoblast with hemorrhage and necrosis. Clinically, both can present with bleeding and high hCG, so classification relies on combining history, imaging, and pathology. Workup should be systematic. Start with pelvic ultrasound to assess uterine disease, then evaluate for metastasis, especially the chest, because pulmonary spread is common. Baseline labs support stabilization and treatment planning. Staging and risk assessment use FIGO staging and AWHO risk score to guide therapy intensity. In an exam answer, always mention chest imaging. Students often forget it. Treatment is chemotherapy, chosen by risk category. Low-risk disease is often managed with single-agent regimens such as methotrexate or Actinomycin D. High-risk disease requires multi-agent therapy like EMA CO. The high-yield takeaway is reassuring. These tumors are frequently highly chemo-responsive, and outcomes can be excellent when therapy is matched correctly to risk and monitoring is strict. Response assessment is objective and biomarker-driven. You follow serial beta hCG until it becomes undetectable, then continue surveillance for a defined period. If hCG rises again after reaching undetectable, treat that as relapse until proven otherwise. This hCG as a real-time tumor marker is one of the most testable concepts in GTD and the core reason follow-up saves lives. Patient counseling is a core management step. Contraception is recommended during surveillance, so a new pregnancy does not confuse hCG interpretation. Patients should also be warned about red flags that need urgent review: heavy bleeding, shortness of breath, hemoptysis, severe headache, seizures, or focal neurologic symptoms. Clear safety netting prevents delayed recognition of metastatic disease. From a histopathology perspective, choriocarcinoma is malignant trophoblast with hemorrhage and necrosis, and the key microscopic clue is absence of chorionic villi. Final recap. After any pregnancy event, persistent bleeding plus plateauing or rising beta hCG demands evaluation for persistent GTD and metastasis, especially to lungs and brain. If this strengthened your exam pattern recognition, subscribe to Histopath Academy, because we teach medicine with pathology at the core.